Welcome, everyone. My name is Zsolt Huszár, and my topic about the risk factors of cognitive decline. Our vision is that in the future, the cognitive decline will be avoidable by the widely used prevention program. That's why our mission is to assist in the development of prevention programs. We have two specific goals. First, we would like to evaluate the association between pathological protein changes and the rate of cognitive decline. Second, we would like to estimate the relevance of different risk factors of dementia. About our first project, the meta-analysis, the title is Risk of Conversion to Neurocognitive Disorder among beta amyloid and phosphorylated tau exposed subjects. There are typical protein changes for Alzheimer's, which could start decades before the cognitive symptom. These changes is the beta amyloid and the phosphorylated tau accumulation in the central nervous system. And although it's known that they play a central role in the development of Alzheimer's disease, but it's still unclear to what extent the presence of these changes accelerate the cognitive decline. This is our question. We investigate cognitively unimpaired subjects and patients with mild cognitive impairment. That means that there is a detectable cognitive impairment, but it's not, it does not affect the everyday life of the patients. The exposures, of course, the beta amyloid and phosphorylated tau, and the outcome is the conversion rate. Here you can see the flowchart of selection. In the end, we analyzed the results of 46 articles. And here you can see the conversion rate from MCI to dementia among the beta amyloid exposed subjects. Imagine that this would be the unexposed, with patient with not pathological amyloid. And this is the exposed side. So we made the meta-analysis of the odds ratio outcome and also for hazard ratio. And you can see that the odds ratio for conversion among the exposed subject is 5.4. The hazard ratio is 3.15. And you also can see that the conversion in 5 years among the amyloid positive subjects is almost half. While half of the population converted in 5 years, while just 15% of the amyloid negative patient converted. Here you can see what happened when not only the beta amyloid but the phosphorylated tau are also measured. How does it affect the conversion? When both two proteins is pathological, you can see the odds ratio for conversion decreases to 11.5. When only amyloid pathological, the odds ratio is 2.9. And when there is no pathological beta amyloid changes, only the phosphorylated tau pathological, the conversion rate is not significantly differ from the unexposed group. Here the unexposed group, of course, the patient with non-pathological beta amyloid and phosphorylated tau level. And here you can see the conversion rate from the CU group to MCI or dementia. The CU mean the cognitively unimpaired groups. We also pulled the odds ratio and the hazard ratio outcome. The results are quite similar. The odds ratio is 6.8 for conversion among the exposed group, and the hazard ratio is 2.3 in the exposed group. And yes, the conversion in 5 years among the amyloid exposed subjects is 16%, while just maybe not just, but by 5% of the amyloid negative patient converted. There are a few limitations. I think the first is the heterogeneity of the population. in the cognitively unimpaired group, there are patients with, without cognitive symptoms and patients with subjective cognitive symptoms. Also, the MCI group differ by the severity of the cognitive symptoms. Also, limitation of different follow-up times, strength a large number of cases, and every measurement technique are accepted in the field. Sorry. So, the conclusion. Abnormal beta amyloid and phosphorylated tau levels greatly accelerate cognitive decline, both in the CU and MCI populations. That's our recommendation for the clinical practice, is that now, by measuring these proteins, the most endangered population can be identified before the appearance of cognitive symptoms. That's why the start of the non-pharmacological, or maybe the pharmacological treatments too, should be related to amyloid and phosphorylated tau status, not the cognitive status. And the research implication that the efficacy of different dementia prevention approaches can be more accurately assessed by knowing the patient's protein levels. The manuscript status is, the internal review is done. We are waiting for, there's a foreign co-author, and he asked time for feedback, and now we are waiting for his feedback. The second project is an observational study about the risk factors of cognitive decline. The currently known pharmacological and non-pharmacological techniques can only slow down the progression, not stop it. That's why eliminating the risk factors and developing lifestyle-changing intervention programs is our best chance to prevent the disease. That's why our aim is to clarify the role of cardiovascular disease, diabetes, depression, and different biological changes, like the mentioned pathological protein changes, neuroimaging changes. Here we also investigate cognitively unimpaired subjects and MCI subjects, the exposure, the lifestyle risk factors like the social activity or physical activity, medical condition like diabetes, depression, and neuroimaging changes and lab values, and the outcome, of course, the conversion to dementia. And of course, the research implication and clinical implication, the disease prevention. This is a multi-center study, and how I mentioned, it's an ongoing study. We already enrolled more than 180 patients. Here you can see the protocol draft, and the primary outcome, of course, the conversion, but we also would like to identify the relationship between the different risk factors and different subtypes of dementia. We also would like to evaluate the performance of the already existing risk estimating skills in our population, and we would like to develop new prevention programs. Here is the overview, and thank you very much for your attention.
Thank you. Regarding your first project, I've got a question that the level of dementia was defined early in all the studies in this plot.
Sorry?
So the criteria of the level of dementia,
yes,
is the same in all the studies?
It's one yes or no. Everywhere is the outcome is dementia, but there is a difference how they assess. Somewhere they defined Alzheimer disease by biologic parameters, other were just the cognitive symptoms, but everywhere the outcome is dementia in every study, of course. That was a question?
Yes, especially the severity of dementia. Because
the severity,
it's a spectrum disease, as I know.
Yeah, of course. But the baseline population, they are not demented. They are with MCI or mixed, and yes, it's a continuous variable, but we use this categorical it's a limitation, but there is a huge change when you are fulfill the criteria of dementia and when you're not.
Okay, thank you.
Zsolt, during our last group meeting, I made a suggestion to define some kind of a cutoff value of what does it mean, having a high tau level, p-tau level. You remember that? And then Gabor promised to take a look into it. Because, you know, it has a very strong message, your paper. But how can we, you know, put it in clinical practice? Because I'm sure it's not a sheer cutoff value that above 5 everybody will develop. So this odds ratio cannot hold true for every single elevated level. Or am I wrong here? You know what I mean?
No, that's even a major question, because there are not only one way to measure the beta amyloid or the phosphorylated tau. It could be measured by PET-CT and by also from the cerebrospinal fluid. So it's a difficult question how is it possible to develop a general cutoff value. But we followed the recommendation of the NIA. We followed the NIA recommendation to detect this.
I have a short question. How can we measure the amyloid and p-tau levels? Because you mentioned we have several options.
By PET scan or by lumbar puncture from the cerebrospinal fluid?
I have a question regarding your first project. So we see some patients, or actually healthy controls, but you analyze the beta amyloid and the tau level. Do we have data on the other CSF potentially important parameters like TDP-43 or progranulin, or, you know, there are many others associating with different types of dementia. So maybe it can at least change your results partially, because if they don't have amyloid positive pathology but they have TDP-43 pathology, they will develop dementia. And then the question is how you diagnose dementia at the end of the day.
Yeah, this can bring far. We focused on these two proteins, and I don't know, we didn't screen for these protein changes.
So
but this could be one source of heterogeneity.
Yeah, of course, yeah. So basically my question is, like, is it available in the papers, or they will focus, because as we do, for instance, as you do and me do, we mostly focus on amyloid and tau. So in many cases we don't have the pattern from other proteins, but maybe we should have.
Maybe we should, but I would like to repeat that only by detecting these proteins,
yeah, sure.
much earlier, we can detect the most endangered population.
Yeah.